We described the Hep C life cycle and the mechanism of action of direct-acting antiviral agents. Now, given a patient with chronic hepatitis C virus, recommend AASLD-IDSA guideline-concordant first-line therapy. Here are some reliable resources. So AASLD and IDSA provide guidelines that can be accessed at their website. Because drug interactions are an issue with the agents used for treatment of Hep C, there's also the drug interaction checker online that you can use. They also have an app that you can download for free. This is from the University of Liverpool, where you can easily check drug interactions and manage if there are significant interactions. Let's take a look at the definition of cure. So sustained virologic response, or SVR, this is defined as undetectable serum Hep C virus RNA at least 12 weeks after completion of treatment, and this is why it's called SVR12. And a sustained virologic response is equivalent to a viral cure because after 12 weeks the virus does not come back unless it's a new infection. So essentially, a cure is important because not only it will reduce the rate of transmission, but also improve clinical outcomes for the patient itself. And these clinical improvement of clinical outcomes includes things in the liver, so hepatic benefits, and that includes reducing the risk of development of cirrhosis, or if the patient already has cirrhosis, reduce the risk of decompensation, reduce the risk of hepatocellular carcinoma, and reduce the rate of need for transplantation, liver transplantation specifically. And then there are benefits outside of the liver. So extrahepatic benefits are reduction in all-cause mortality, and all-cause mortality, obviously liver-related mortality, but also non-liver related mortality. These are all shown to be improved with the cure. Improved quality of life, of course, malignancy, diabetes, cardiovascular disease, renal, and neurocognitive benefits. And in fact, the guidelines say the goal of treatment of Hep C patients is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease and hepatocellular carcinoma, by the achievement of virologic cure as evidenced by an SVR. Now, it's important to note that virological cure does not protect against reinfection. So if someone has RNA levels detectable after 12 weeks, is essentially a new infection if they did not stop the risky behavior that gave them Hep C in the first place. Now, Hep C cure significantly reduces incidence of type 2 diabetes, and this is important because patients with Hep C have 2 to 3 times greater odds of diabetes. And cure may prevent and improve insulin resistance, and that's important because insulin resistance and diabetes increase risk and rate of fibrosis. And as we know, in patients with diabetes, there is also risk of renal and cardiovascular disease. So in this graph, you can see on the x-axis, we're looking at time in years, and on the y-axis, cumulative incidence of end-stage renal disease. And you can see essentially the gray line is untreated patients with diabetes and hepatitis C. As you can see, year after year, the rate of end-stage renal disease goes up. The orange line is untreated patients who have diabetes but not Hep C. So if someone has diabetes and Hep C, the risk of end-stage renal disease is significantly higher than someone who just has diabetes. And the green is people who have diabetes and Hep C but receive treatment for Hep C, and you can see that we can bring that risk significantly lower than people who have diabetes and no Hep C. In fact, the guidelines say treatment is recommended for all patients with acute or chronic Hep C, except those with short life expectancy that cannot be remediated by Hep C therapy, liver transplantation, or another directed therapy. Patients with a short life expectancy owing to liver disease should be managed in consultation with an expert. Let's take a look at treatments for genotype 1. Genotype 1 is by far the most prevalent in the US and worldwide. So these are the treatments. So essentially we have 5 regimens in the US that are active against genotype 1. It's good to think of genotype 1 as genotype 1A and 1B subtype because the recommendations are slightly different. And then for each of these, it's important to consider patients with no cirrhosis, patients who already have compensated cirrhosis and patients who have decompensated cirrhosis. So you can see that Harvoni, which has ledipasvir, sofosbuvir, green means first line recommendation for all of these patients. So 12 weeks of treatment is recommended for genotype 1A and 1B. Now there is an asterisk here because there is a subgroup of these patients that may actually benefit from just 8 weeks of treatment. So 8 weeks instead of 12 weeks is recommended for ledipasvir, sofosbuvir if the patients do not have HIV and their baseline RNA level is less than 6 million. And these are, of course, for treatment naive patients. These are people who have not been treated previously and failed. So if the patient does not have cirrhosis, they can get 8 weeks of treatment if they meet those criteria. Otherwise, if the viral load is more than 6 million or if the patient has HIV co-infection, 12 weeks is recommended. Now, if the patient already has compensated cirrhosis, 8 weeks is no longer an option with this regimen. You do have to treat for 12 weeks. And when it comes to decompensated cirrhosis, that's more difficult to treat. So 12 weeks is not sufficient. So you may need to do 12 weeks, or if you want to do 12 weeks, you will have to add ribavirin. So ledipasvir, sofosbuvir plus ribavirin for 12 weeks for patients with decompensated cirrhosis. Now, in general, as you can imagine, 12 weeks is 3 months of treatment. If you do 24 weeks, that's 6 months of treatment. So, that's very difficult to be on a treatment for 6 months. So ideally, we want to get patients to receive 12 weeks of treatment. That's easier. But they may or may not be able to tolerate ribavirin. So it's a matter of whether they can tolerate ribavirin. And ribavirin, most notoriously, it can cause hemolytic anemia. And as we know that bleeding is an issue with decompensated cirrhosis. So, if the patient has significant bleeding going on that may not be able to tolerate ribavirin, then we may have to do 24 weeks of treatment without ribavirin. Now, similar recommendation for genotype 1B. When we look at velpatasvir, Glecaprevir, it is first line recommended for genotype 1B, but not for 1A. And this is 12 weeks of treatment. And the reason it's not recommended for 12 weeks for genotype 1A, because genotype 1A could have some resistant associated substitutions that can reduce efficacy of 12 weeks of this regimen. So for those patients, you essentially would need to treat for longer or add ribavirin. And because we have other regimens that are effective for these patients, for that reason, if the patient has positive NS5A RAS and the patient must be tested at baseline before we can use this regimen for genotype 1A. So if they test positive for these RAS, then something else should be used. Next, we have Sofosbuvir, velpatasvir, which is actually pan-genotypic. So this covers all genotypes, including genotype 1A. So 12 weeks, is recommended first line. And similar to Harvoni, when it comes to decompensated cirrhosis, either 24 weeks of treatment or add ribavirin. Now, Sofosbuvir, velpatasvir, Glecaprevir has a third agent on top of that. Now, you will see that it's not recommended, and primarily because this is an overkill. So it's not that it won't work. It will absolutely work. But, we reserve this for people who fail other regimens because this is very potent. So for that reason, it's not recommended. But also in decompensated cirrhosis, we cannot use anything that has protease inhibitor. So Glecaprevir is contraindicated in decompensated cirrhosis. The same is true with Glecaprevir. Glecaprevir is a protease inhibitor, so it's contraindicated in decompensated cirrhosis. The same is true with pibrentasvir. Glecaprevir. Glecaprevir is a protease inhibitor, so it's contraindicated in decompensated cirrhosis. Now, Glecaprevir, pibrentasvir, this regimen is probably the most commonly used because 8 weeks of treatment is recommended for genotype 1A and 1B, whether they have cirrhosis or compensated cirrhosis. So that makes treatment much easier because this is only 2 months of treatment. So here's what's in Harvoni: Sofosbuvir and ledipasvir, so in a single tablet. And you will see that Sofosbuvir is mostly renally clear, so 80% of it is in the kidneys. And it used to be contraindicated in people with end-stage renal disease. However, since a few years ago, the package insert has been updated that no dose adjustment is required in patients with renal impairment, including end-stage renal disease. So more studies have come out and showed that it's actually safe and effective, regardless of the degree of hepatic impairment. Now, Sofosbuvir has the highest barrier to resistance. So because this is affecting the polymerase, so it's a polymerase inhibitor, and the polymerase is highly preserved, conserved. So there are so mutations in the polymerase come at a high fitness cost to the virus. So for that reason, resistance to Sofosbuvir is very rare. Ledipasvir, on the other hand, has a low barrier to resistance. So when resistance does occur, it typically happens to be to ledipasvir, which is a NS5A inhibitor. Next, we have Glecaprevir, which has elbasvir, Glecaprevir. This is also a single tablet, and it comes in a blister package as opposed to in a bottle. And it has two regimens, and both of them have high barrier to resistance. So these are second generation NS5A inhibitor and NS3 inhibitor. So second generation essentially means a higher barrier to resistance, but also less adverse effects. Whereas previously ledipasvir is a first generation NS5A inhibitor, so it has low barrier to resistance. Next, we have Epclusa, which has Sofosbuvir and velpatasvir. So this is similar to Harvoni. The only difference is velpatasvir is a second generation NS5A inhibitor, so it does have a high barrier to resistance, and it also has the same Sofosbuvir, which has high barrier. So overall, this is a very effective regimen, and it's pan-genotypic. Whereas Harvoni does not cover genotype 2 and 3, it's only for genotype 1 and 4. Now, next we have Vosevi, which on top of Sofosbuvir and velpatasvir also has Glecaprevir, which is a second generation protease inhibitor. So all three of them have high barrier to resistance. So that's why I say this regimen is highly effective in patients who fail other regimens. So we reserve it for those patients. Maviret has Glecaprevir and pibrentasvir. This comes in 3 tablets, but it comes in a blister package. So one package is for 1 day, and it comes in a box that has seven blister packs in there. So for each box is for 1 week. And this also has 2 second generation drugs in here. So second generation protease inhibitor and second generation 5A inhibitor. So high barrier to resistance. And this does need to be taken with food, and it's not renally cleared. Now, genotype 3 is very important because it's not only is the second most common genotype globally, but it's also relatively more difficult to treat historically. So when you see in this graph, on the x-axis we're looking at years, and on y-axis we're looking at hepatocellular carcinoma-free survival. So the higher, the more survival. And you can see that when you compare different genotypes, as time goes on, genotype 3 has the worst outcome as far as survival. So fewer people with genotype 3 survive. So for that reason, it's important to have effective treatment for genotype 3. And when we look at our regimens on the market, of the 5 that we have, only 3 of them are active against genotype 2 and 3. So at the top, we're looking at genotype 2, and at the bottom, we're looking at genotype 3. So with Epclusa, which has Sofosbuvir, velpatasvir, 12 weeks of treatment is first line for genotype 2 for no cirrhosis and compensated cirrhosis. And of course, with decompensated cirrhosis, you either do 24 weeks of treatment or 12 weeks with ribavirin. For genotype 3, again, 12 weeks of treatment for no cirrhosis. It gets tricky when it comes to compensated cirrhosis. So these patients are with genotype 3 who have cirrhosis are more difficult to treat, and resistance becomes an issue with this regimen. So we do need to test for NS5A RAS, specifically Y93H mutation, And if we do detect this mutation, then this regimen may not be as effective. So it's alternative at that point. Otherwise, if the patient does not, if the patient tests negative for this test, then 12 weeks of treatment is first line. Now, Vossevi in general we reserve for people who have failed other regimen, except for genotype 3 compensated cirrhosis. If they do have that RAS, essentially because we don't have a lot of options, we only have Mavyret left, this becomes an alternative regimen for these patients. Otherwise, we reserve it for people who have failed other regimens, and of course, Vossevi is contraindicated in decompensated cirrhosis. Last, we have Mavyret. Again, Mavyret by far the most commonly used because it's 8 weeks of treatment, and across the board, it's effective for genotype 1, genotype 2, genotype 3, whether the patient has cirrhosis or compensated cirrhosis or no cirrhosis. 8 weeks is effective. Now, of course, it's contraindicated in decompensated cirrhosis because of the protease inhibitor in it.